On behalf of the Department of Medicine, we would like to welcome our guest and, of course, our guest faculty, Dr. Schilsky, for participating in our 15th annual Carroll Morton Leevy Memorial Lecture. And a couple of words regarding Dr. Leevy. He was born in South Carolina in 1920. October 13, and he attended the Booker T. Washington High School in Columbia, South Carolina. After that, he moved in Nashville, Tennessee, when he attended the Fisk University in Nashville, and he graduated with honors. He moved to Michigan, and he attended the University of Michigan Medical School, and he completed his residency and chief residency at Jersey City Medical Center. He actually joined the military, and he was in specialized training program and subsequently in the Navy. Now, what it is very appealing is that while he was in medical school, he was nominated actually by the president, Franklin D. Roosevelt, for a membership on the National Advisory Committee of the National Youth Administration. Why did this happen? Because he had already embarked on investigating and studying inadequacies in healthcare, education, and also segregation. And this was a very special career path. His work took him to the White House, where he presented his findings. And at this point, Eleanor Roosevelt and Mary McLeod Bethune, that she was one of the major philanthropists, were devoted to improving the situation he reported. But unfortunately, World War II took precedence at this point. He received a Kellogg Foundation fellowship, and also he had a job waiting tables, and this helped him to finance his education, while the United States actually was involved in the World War II. And at this point, a shortage of physicians was identified, and Dr. Leevy entered the Army Specialized Training Program. At this point, he received a monthly stipend, and this helped him to fund his education and gave him more time to concentrate on his studies. He finally joined our center many years ago, and he established perhaps the first clinic for alcoholic liver disease in Jersey City Medical Center in 1948. He was the chairman of the Department of Medicine and the physician in charge at UMDNJ from 75 to 91, and he was the first African-American president of the American Association for the Study of Liver Disease in 1967, which is a humongous accomplishment. He became the president of the International Association for the Study of Liver Disease in 1970, and the scientific director of the New Jersey Medical School Liver Center in 1990. Also, he was the scientific director of the Sammy Davis Jr., the famous actor who suffered from liver disease, and he was flying from California to New Jersey in order to have his care given by Dr. Leevy. What is appealing is that in 1998, he was asked to present in the subcommittee of government reform and oversight on hepatitis C. And he stated that we need to raise awareness as the disease was on the rise, and people didn't know about that. Also, it is essential to target educational efforts to the medically underserved. And this is a continuous battle he was giving regarding diversity and how people with minorities or disadvantaged Americans have no access to routine lay educational care programs. In 2002, he was asked to review the medical records of an inmate, and at this point, they realized that there were approximately 1,100 inmates in New Jersey, and none of them had been treated regarding the disease, and even worse, they didn't know that they suffered from the disease. So this actually raised awareness in New Jersey regarding hepatitis C. Over here, you can see Dr. Young young Dr. Leevy, and this is Dr. Leevy actually with the dean and Sammy Davis. He had a leadership role in UMDNJ. He has published 6 textbooks and more than 500 articles. And what is appealing that back in the 60s, 1962, he's one of the first who mentioned fatty liver disease in non-alcohol related setting, which is a groundbreaking situation. Having said that, I am excited to introduce Dr. Michael Celski. Besides that, he's a great friend. We are honored having him as a guest in our Department of Medicine Grand Rounds. Mike received his medical degree from the University of Chicago, and he completed his residency and fellowship in gastroenterology and research training in liver disease at Albert Einstein College of Medicine and Montefiore Medical Center. He became the director of liver medicine clinic at Mount Sinai, and he formulated a wonderful clinic at Cornell. After that, he moved to Yale, where currently he is a professor of medicine and surgery and the medical director of the liver transplant program and the director of the transplant hematology fellowship. I think that he is the world's authority on Wilson disease. He has written multiple papers, and currently he is the author of the guidelines for the American Association for the Study of Liver Disease. Let's extend a warm welcome to Dr. Schilsky, and looking forward to your presentation.
Thank you kindly, Nick, for your kind words. And it's really a great honor to be talking to you today. When Nick told me that this was the Carroll Leevy Memorial Lecture, I was really thrilled. And I was reminded that as a young fellow bringing a poster presentation to the Digestive Disease Week, I was in the aisle talking to my mentor, Professor Erman Sternlieb, and he looked down the aisle and he pointed to Dr. Leevy and he says, "Do you know who he is?" I said, "Yeah, I know who he is, but I've not had a chance to meet him." And the very words from Dr. Sternlieb were, "He's a man worth knowing." And I think the contributions he's made to our field and to the state of New Jersey and the center locally speak for themselves. He was certainly a pioneer in many ways. So it is really a great honor to present in his namesake today. And a note to those wanting to collect their CME information, please, down on the bottom, there's a text code 11740, and we'll show it at the end as well. So I'm going to talk to you today about a disease which I've been involved in caring for patients since my fellowship days, Wilson disease. And I'll sort of talk to you a little bit how this fits in overall with liver disease, but specifically about the changes and the advances that have occurred throughout this journey. Here we go. So these are my disclosures, which are only grant support. So I'm going to focus on the approach to Wilson disease diagnosis, talk about some of the treatment options, hope to improve your understanding of monitoring treatment and how that fits in with the pathophysiology, and talk a little bit about the future, what lays ahead for both diagnosis, treatment, and monitoring of these patients. Now, it's also rather interesting that Wilson disease is named after Professor Wilson. He himself did not have the disease. Of interest, he was born in New Jersey, although he spent his academic career in the United Kingdom, and published in this wonderful monograph, which is actually available online should people wish to see it. He really focused on these very interesting patients who presented with neurologic disease. Now, the basal ganglia of these patients were affected, as shown in the picture here. But the important part is in his day, he attended the autopsy of his patients, and he recognized that the liver was cirrhotic in these individuals and postulated that there was a common toxin that was affecting both the liver and the brain. And this was really very forward thinking and led to a number of discoveries that moved us over years that recognized that that toxin indeed was copper. And in the days before the molecular diagnostics were available and before we had the actual basis of the disease understood, looking at these rare diseases gave us a window into understanding the normal metabolism of some of the various different trace metals, in particular copper. So this is a little cartoon that shows the normal metabolism. And we learned that dietary copper is an essential element, so we cannot create it. We must ingest it from our diets. Our intestines absorb it, but the liver is sort of the clearinghouse for it. Anything present in excess goes out into the bile, and unlike the bile acids, these are not recycled and it appears in the stool. That which is absorbed into the liver is then utilized as well for metabolic needs, and many different enzymes have cofactors, cytochrome systems being a great example for that. But the liver is also in equilibrium with a small pool of copper that is what we call the non-ceruloplasmin copper pool, and that's the copper that's available for bioutilization by other tissues. And in the normal circumstances, only a very small amount from that pool which is excreted into the urine. Now, the liver also produces the protein ceruloplasmin, which is a glycoprotein that contains between 6 and 7 copper atoms per molecule of the protein or the peptide backbone. And this actually isn't a copper protein in the sense of serving for copper metabolism, but is really subservient to iron metabolism, in that this protein is what we call a peroxidase. It allows the mobilization of iron through changes in its oxidative state. So we don't, even if you lack ceruloplasmin totally, you will not have a disease of copper. Now, you will actually have a different disorder called apoceruloplasmin, which leads to changes in iron metabolism. But it turns out that in Wilson disease, it's a phenotypic marker, and this was first recognized by Scheinberg and Gitlin back in the 1950s, who recognized there was a reduced level of this protein in the circulation, and I'll talk to you a little bit about the basis for that. Now, in Wilson disease, the basis for the disease, even before we understood how the gene functioned, was a recognition that there was a decreased biliary copper excretion, and that over time, individuals who were born with this disease would accumulate copper in the liver, and that would then subsequently lead to organ damage in the liver, and also an increase in that equilibrium pool with the non-ceruloplasmin copper, which would allow copper to deposit in other parts of the body. The most critical one is the central nervous system, hence leading to the findings that you typically see that were described by Wilson originally. And also secondarily, you started to see increases in the urine copper, which came into play in terms of diagnostics. So again, you have high liver copper, and then over time, especially in symptomatic patients, increased urine copper as well, and a decreased ceruloplasmin. And that is sort of the hallmarks of leading to some of the early diagnostics for this disorder. Now, this is the basis of the disease, and it was discovered simultaneously, interestingly, by the original Gitlin's son, John Gitlin, as well as Conrad Gillam, who was at Columbia, and Diane Cox, who was in Canada. And these three individuals' laboratories came upon this same molecule from different directions. But in the end, what they found was this interesting transmembrane protein, which lived mainly within the cells, highly expressed within liver cells, as one would expect in dealing with the sorting of copper. And what you see is the N-terminus of this molecule has very cysteine-rich regions, which serve as almost sensors for the amount of copper. And then the central membrane channel, which allows the passage of copper from one side of the membrane to the other. This is a schema of a hepatocyte, sort of showing you where this protein would sit. And you see that yellow box shows you that it sits mainly at the transgolgi in the basal state. And here it's an important site because this serves to allow it to both produce ceruloplasmin because it puts copper into the glycoprotein at that stage of its biosynthesis, and that is exported out of the cell. But importantly, it's also a sorting site for what we call intrahepatic vesicular recycling, where you make these endosomal lysosomal vesicles which butt off the transgolgi and then merge with the apical membrane, which is the bile canaliculus, allowing copper to go out in that direction. So there are many different aspects of the cellular metabolism, but when you perturb this particular protein, what happens is you fail to put copper normally into the protein ceruloplasmin, and so therefore you still have the peptide being made and put out into the circulation, but it's a less stable peptide lacking its copper complement, and that's what actually gives us the phenotypic reduction of the ceruloplasmin. And similarly, the lack of the function of that protein in this export pathway is what leads to the accumulation within the hepatocyte, ultimately within the liver, and then later in other parts of the body. So we need to think about who should we consider Wilson disease in. Now, this is a disorder that's present in about 1 in 30,000 in all populations. It's autosomal recessive, and so it is equally present in women and in men. But in thinking about where it fits in the larger scheme of things, you know, this is an uncommon disease, but you have to start thinking about it when you find individuals who do not have an explanation for their elevated liver tests. In particular, there is steatosis early in the injury to the cells. And this overlaps, as we know, with this sort of sea of NAFLD and NASH that is out there right now. You also may consider it, especially in pediatric patients whom were given a diagnosis of autoimmune hepatitis but failed to respond to standard therapy for that. Patients who have cirrhosis of unexplained etiology, or the rare patient, and this occurs in about 5% of patients with Wilson disease who present with acute liver failure, often associated with hemolysis as well. Now, age alone shouldn't exclude the diagnosis, though most patients are diagnosed before the age of 45 years. We have had outliers, and we've reported on patients who've been diagnosed at age 70 and 72, and there have been even some that have been reported even older than that. These are rare, but it is a disease with high penetrance, so that if one looks even at those patients at any point in time, they could have been diagnosed earlier. But fascinating that they have such a wide degree of phenotypic variation. Some will have the liver disease and then later develop the neurologic and psychiatric. Some may have liver disease alone for their entire life, and some may have silent liver disease and present with psychiatric disease or neurologic disease. So it is really has had a name of the great mimicker. Because of that, it may present many different ways. Now, other people we have to consider the diagnosis in are first-degree relatives of these individuals, and it's really very important once you identify that individual to do the family screening. You can have Coombs negative hemolytic anemia due to the copper, even in patients without acute liver failure, and this may be a tip-off in some cases of unexplained hemolytic anemia. Again, if you have neurologic symptoms with unexplained especially in association with liver disease, or similarly psychiatric symptoms as well with liver disease, needs to be ruled out. I've had rare patients who've gone to have their eyes refracted or something else happened, and surprisingly asymptomatic, and yet they were found to have the pathognomonic, what we call Kaiser-Fleischer rings, which is the deposition of copper in the Descemet's membrane of the eye, and so they've been found that way too rarely. Or individuals who may have had tremor, some other neurologic feature that led to them having brain imaging, and the imaging was suggestive that they need to exclude this disorder. Now, we've even had individuals now who've had molecular studies done looking at this ATP7B gene and finding disease-specific mutations, one on each allele. And we've had now individuals who are doing all these molecular testing, even during the phase of being just pregnant, looking mother, father, and then even looking in utero. And so this poses a unique problem of finding disease at extremely young age and a quandary about what to do, because we need copper for development, and yet the copper that accumulates too much is injurious. So a very special balance has to be considered. Now, to make the diagnosis really is a combination of clinical and biochemical findings. And because it is sometimes so difficult, many years ago, back in 2002, a number of experts, and at that time I was a young expert in the area, and we joined in together in the town of Leipzig, which is why this became known as the Leipzig scoring system. And what we did is we looked at the different clinical and biochemical features, tried to give them a graded weight to generate a score. And this score is held up over time, and we've used it now for both clinical aid as well as in research purposes to make sure all our patients have uniform diagnoses. And it looks both at the, as I mentioned, clinical, biochemical, and it was the first, even back in 2003, to recognize that we should start including the molecular diagnostics, and when we have these disease-specific mutations, assign them a very high score. Now, at the time that came out, the diagnostics for molecular studies were being done only in research institutions and was not done as a standard clinical test. That has changed dramatically, and that's been actually one of the big changes in our clinical practice, is incorporating that in our current algorithm for diagnoses. But anyway, when you use these, you can check all the boxes. If you've done a couple of them and you find you have some partial success and may see some positive score, then you need to then complete it through before you can actually exclude the diagnosis. So it really is a very useful tool. Now, we have been discussing the diagnosis, and part of the problem is now updating with many of the newer changes so that we can incorporate these into the guidances provided by our societies. Please, as Nick pointed out, I was involved in both the 2003 and 2008 iterations of the first guidelines that were produced for Wilson disease. And we are currently about to release we were hoping last year, but the committee has slowed us, but we hope to release the guidance coming in this year. And this time we've expanded our author group to include not only other pediatric and liver disease specialists, both from here as well as across the ponds and in the UK. But we've also included pathologists, neurologists, dietitian, and psychiatrists, recognizing this sort of very wide phenotype and also the need to address the various different needs of our patients, and that sometimes these multidisciplinary models that we've put often for transplants or other things may come to play very keenly for a disease like this, which may have very different manifestations. So what are some of the new things that are going to come out? We've taken some of the algorithmic approaches and incorporated some of the molecular diagnostics and clarified them a little bit further. And so we hope that we've included one for liver disease, one for neurologic disease, one for family screening. We have emphasized the utility of using the molecular diagnostics, especially now that it's available through a number of various CLIA-certified laboratories. And we've acknowledged that occasionally the molecular diagnosis comes to us unexpectedly, both in the screening of newborns or even in utero. And even now, many patients go and get these extended gene panels, and we may find the disease looked at from that angle. I'm going to show you in a moment sort of an improvement on just the standard slit lamp exam, looking for the Kaiser-Fleischer rings. And I should mention that we also, years ago, used to liver biopsy almost every single patient, but now we have, if we have the molecular diagnostics and then we want to know how the liver status is, we can use some of the non-invasive methodology as well for evaluating hepatic fibrosis and incorporate that into our practice as well to understand whether our patients are non-cirrhotic or cirrhotic, which may have implications for treatment and their prognosis in the long run as well. So, oops, we'll come back here a second. These are pictures of the eye, and you can see the corneal Kaiser-Fleischer ring when it is really very advanced. You can see it circumferentially. In earlier stages, you see it in the superior and the inferior part, and this would be not present at all. And then if you do this tomography, which many of our cornea specialists use for different purposes, you can actually look for the Kaiser-Fleischer rings. So sometimes we're, told there's rings and we're not sure whether the other parts of the diagnostics don't fit. We say, go back and get these tomography done now. And you can see where the arrows are, the formation, and especially it expands to be more inclusive as you see the increase in the rings. Now, as the disease is treated, similarly, these rings will disappear, and the reappearance of the rings may be very telling for patients who are non-adherent or whose therapy is failing. Now, another advance that's come up, which is really fascinating, and this was published last June in Gastroenterology, and there was a nice editorial about that, is the interesting finding that you can actually look in white blood cells that are included in dried blood spots. And then you can digest these and then immunocapture the peptides to the ATP7B protein. And this is just off dried blood spots. It's really fascinating. And then using very sensitive methodology, you can look at the quantitation of the recovered peptide. And we found, and I credit all the work to my colleague Si-Hoon Han out at Seattle Children's, and Si-Hoon has been searching for ways to do neonatal screening for this disease, and especially things that would be viable even if you don't have big refrigeration or anything, hence the dried blood spots, which can then be stored and then shipped to a laboratory like his, where he looks and he found that the immunocapture of the peptide in patients with Wilson disease was far lower than those with normal controls. And so this is being worked on further and tested in larger populations now. We'll see whether this will be indeed the first potential neonatal screening test, separate from the molecular testing, which is another option nowadays as well. So what hasn't changed? Now, when we, if you don't consider the diagnosis, and this is something that the partner to Dr. Sternlieb, Dr. Scheinberg, had taught me, goes, if you don't think of it, you don't find it. And so we really need to consider it somewhere in the background when we fail to understand why the disease is advancing in some individuals that do not have a clear diagnosis. Now we have to recognize we can use the ceruloplasmin as a screening test, but alone it's not sufficient. So we have to go through the exercise of looking for that combination of things that give us a high enough probability. The other thing is all testing, whether it's ceruloplasmin or 24-hour copper or even liver copper, is a trade-off between sensitivity and specificity. So if you set your bar very high, you'll be very specific. If you set the bar lower, you'll be more sensitive. So one of the things we learned is that in using the basal copper excretion for patients, 24-hour testing, which indeed is much better than any spot testing, that if you set that bar a little bit lower at 40 micrograms per day, you're going to pick up some carriers of the disease, but you'll also pick up almost all the patients. Whereas if you leave that bar much higher at the 100, which is the other cutoff, which is more specific, you will, lose in the diagnostics for patients. Now, another interesting thing, and I credit my mentor with this work, was recognizing that the early phase of disease and copper accumulation in the liver led to some of the mitochondrial changes that he well described, dilated cristae and other crystalline deposits, as well as later lysosomal dense collections, which were copper and copper metallothionein complex. But that this can actually be a useful diagnostic when you have complicated cases and there's overlap in phenotype and you're not sure, and say you come back with only one found defect of the gene when you study that as well. Ultrastructure can still be useful in helping to look at that, and indeed those ultrastructural changes disappear with appropriate treatment of the disease as well. And the other important point is it's very important to really firmly establish and make sure you get it right, the diagnosis, because medical treatment is lifelong for these individuals. And it really is important once you embark on that to get it right. And that also sets you down another path for doing family screening. So one of the things that we've included in the new guidance has been a concept that I've been trying to introduce for a while, which is that understanding how to approach the treatment of this disease, you really need to know what phase of the disease you're in. And so this is a timeline of untreated Wilson disease shown from left to right, ultimately untreated, leading to death of the individual. And early on, you see the hepatic inflammation, non-specific symptoms, and then with time, you go from the liver to advanced liver disease. And then you may have the appearance of neuropsychiatric symptoms, rarely before the cirrhosis, but often after cirrhosis occurs. And then ultimately untreated leads to liver failure and death in these individuals. This is excluding the 5% that have acute liver failure. That's a complicated story for another day. But in those who have advanced liver disease, you also then have to deal with the same things we deal with all our other liver patients, the complications of portal hypertension, ascites, variceal bleeding, encephalopathy, even the development of hepatocellular carcinoma. So when you look at these individuals along the timeline and you want to think about treatment, it's important to recognize that when you have minimal disease and really no significant tissue damage, what you're trying to do is prevent disease progression. When you have advanced disease or significant findings, then you're really treating the disease to try to then reverse those and push those back into that preventive kind of treatment. So the initial is significant treatment, and then maintenance is really more prevention of moving along that line. And then there's a small percent of patients where we're teetering on the edge just before liver failure, where we can try rescue therapy. And then if you tilt over into the liver failure, whether it's chronic or in the acute patient, then the only thing that can save you is really liver transplantation, which, because this gene is so highly expressed in the liver and functional there, if you replace the liver, it's indeed just similar to like achieving a sort of a gross form of gene therapy for these individuals. So this is the sort of the timeline going back to Wilson of sort of development of therapy for Wilson disease. So even though he described it in 1912, it took until 1950s to recognize that you need to go after the copper in the disease. British anti-lewisite was an injectable compound, not very palatable for individuals. But in the beginning, people were only treating symptomatic patients because those were the only ones they can recognize. There was no liver biopsy until later in the 50s, and people weren't really focused on the liver tests, or they were not available in the same way. And so it was only symptomatic treatment, and this transitioned during the 1950s through the early 1960s. And that is another thing that both Scheinberg and Sternly went to bat for these patients to start treating them preemptively, and published a very nice New England Journal article about that back in the early 1960s. But the first therapy came about, and the first two therapies came about really by a fellow named John Walsh, who is now approaching his 100th year of life in the UK. I had the great pleasure of meeting him through introduced from my mentors, and then seeing him later in life presenting at a centennial celebration for Wilson. And he was actually the first one to recognize that you can construct a molecule that would have a sulfhydryl group that was reactive, and he had a chemist make D-penicillamine. And sort of in that day, the experimenter also was the experiment, and he took a gram of it, didn't harm himself, saw that the urine copper went up, and said, well, that's pretty safe, and let's give it to some patients now. And he actually demonstrated the increase in the copper in the urine in those individuals, and ultimately that became the first oral therapy for Wilson's disease. Now, those in GI will certainly know that the same principle being the experiment, which was frowned upon, led to a Nobel Prize for development and recognition of treatment for Helicobacter. So certainly it's really not unheard of, although we try not to be our own experiment these days. Subsequently, it was recognized by the Dutch that you can use zinc to inhibit the absorption of copper from the intestine, and that can be a potential treatment for Wilson's, and that there was a need for a second chelating agent, which would remove copper by the urine, because a number of patients with D-penicillamine had either hypersensitivity or intolerance reactions. And so John Walsh had a chemist synthesize another compound and sort of had a polyamine-like structure that bound copper between its nitrogen and oxygen, and again put it out in the urine, and that compound is known as trientine. Early on in the phase of transplant, Starzl actually stumbled upon a patient that had Wilson disease and transplanted them, and reported the probably first successful transplant for a patient with Wilson disease, again proving the principle that the liver was the central place where that disease was being affected. Late in the 1970s, and especially because of the paradoxical worsening of some patients on D-penicillamine, was development of another compound called Tetrathiomolipdate. Interestingly, we borrowed this from the veterinarians who knew that this could effectively chelate copper that poisoned animals when copper, because copper sulfate had been used as a fungicide for years, but when it poisoned the food of animals, it turned them yellow by the virtue of causing liver disease in them, and they used tetrathiomolipdate to treat that. And then George Brewer adopted that and put it through some of the early paces. And then more recently, there's been a stabilized form of it, because the original compound was very unstable, would oxidize rapidly. So there's now a choline form of tetrathiomolipdate that undergone clinical trial. I'll show you some of the data on that. And now, believe it or not, there actually is the initiation of gene therapy trials for Wilson disease, which have launched in this past year. So it's really undergone a really transformation from untreatable and just recognizable all the way now to potentially cure. So when we consider the treatment, we have to consider those things that are directed towards removing that excess copper, and I call those primary therapies, and then those that are really treating the complications of the disease. So the primary ones include diet. So we tell our patients to reduce their copper intake, avoid the high copper foods, which is usually things like shellfish, lobster, mushrooms, chocolate, dark chocolate, not the white chocolate, which doesn't contain the cacao, which has the copper, and nuts, which are high in that. Those are the real biggies. In terms of pharmacotherapy, I mentioned the chelators. D-penicillamine, trientine have been our mainstays for a number of years. Zinc has been introduced as a maintenance therapy by blocking the copper absorption. Works a little differently. So these pull it out. This blocks it. And I mentioned transplant as that rescue therapy. And then if we have complications of portal hypertension, we really don't treat that any differently than we should for any other liver disease. So they need screening for varices. They may need treatment of the varices, whether that's banding or use of non-selective beta blocker. We should screen these patients for HCC, is my belief, even though that left a question mark, because it's always a question of what is the real true incidence, and does it buy into the standard that our society has set, liver society, for screening for hepatocellular carcinoma. Definitely, we need to treat the symptoms of patients, whether they're neurologic or psychiatric. Even though we're treating the primary basis of the disease, these individuals benefit from liver-safe treatments that may make their symptoms much better. So when we consider monitoring these individuals on therapy, we have to consider both the clinical and the biochemical aspects of that. And importantly, you want a functional patient. Years ago, just surviving these patients was enough. But now I think we need to survive them and also improve their quality of life. So we have to really look at them in a very global way, and characterize them. Do they have liver disease, neurologic, psychiatric, and how do we address their problems? We need to look at the liver tests, and assuming that initiation of therapy should improve this, we have to then follow that to show that that happens. We also need to show that some of the parameters of copper metabolism, which may be perturbed, also improve. And that also tells us a little bit about the effectiveness of the treatments. So if we consider these when we treat a patient who has, say, in a symptomatic patient, starts off with greater than 100 micrograms of copper in the urine per day, normal in most of us is going to be between 10 and 20. And you initiate chelation therapy, it's going to drive it up over to 1,000, sometimes even 2,000 milligrams. But what should happen over time is their stores are decreased. You should start to see reductions, and it should go down between 1 and 500. Now, the opposite happens with zinc therapy, which blocks absorption, and that urine copper, which starts at greater than 100, should decrease to less than that over time. Now, we do recommend twice-a-year monitoring for our patients, and monitoring for adherence is very important because patients who may get better once they stop their therapy may actually go on to worsen. Some who may have been arrested at a point of disease where they may not have had neurologic or psychiatric, if they are untreated later on or poorly treated, they can then go on to get these other symptoms. Now, what we hope we're going to come upon very soon, and I'll share a couple of slides on that, is what we think may be the best biomarker of the copper balance, and that's looking at what we call non-ceruloplasmin copper. So one of the things we do look for when we start treatment, and again, that's sort of important, is sort of not to fall in the morass of not understanding where the treatment may go. So we do have to consider, especially in those with neurologic symptoms initially, that a number of these individuals, and it's ranging, depending on the study, between 10 and 25%, can actually get worse initially with the treatment of D-penicillamine trientine, which led us to change our practice to sort of go low and slow with initiation of therapy. And that's also why we've tested the compound tetrathiomolipdate, because it may bind the copper in a less bioavailable form. Now, the other thing is, we have to really think about what is treatment failure, and that's something we've defined better in our guidance. After a period of 3 to 6 months, if you're failing to show significant improvement in your liver test, if your clinical features are worsening, you have to reassess whether it's the patient not taking it, whether the patient's taking it and it's not effective, or whether there are other complicating factors to that. So it really deserves a careful investigation. We have to also recognize there are some special circumstances in which we have to adjust therapy, pregnancy, preoperatively. And we also have to think that in patients who've been treated for 10, 20, 30 years, that in certain instances, we may need to back off on therapy because these patients could be potentially driven to a point where they can have a copper deficiency state or relative copper deficiency state. They may manifest neutropenia. They may start showing some of the neurologic signs that can occur, which mimic posterior column disease from a copper deficient state. And they may actually accumulate iron because you've driven away any peroxidase activity in patients. So we have to find that sweet spot of treatment, not too little, not too much. It's sort of almost like Goldilocks. Now, to improve our treatment, we have to recognize that we can use the urine copper as one parameter. But one of the things that over the years in the past we've done is say, okay, how can we estimate that non-ceruloplasmin copper and use that as our target? Because really it's the copper in the circulation that leads to deposition in other organs and complications. So we used to say, take your total copper and subtract off ceruloplasmin times 3.12, and that's in milligrams per deciliter, and you will get sort of an estimate of non-ceruloplasmin copper. The problem with that, in 30 to 40% of patients, you had either a zero or negative number. And we had patients who were so fixated on calculating that and they couldn't understand that. And it became the bane of our existence. So we're kind of de-emphasizing that now, and especially in light of other ways of measuring that non-ceruloplasmin copper. And that's actually started to be used in one of the most recent clinical studies as well. So back, and this goes back probably about 5-6 years ago, we started conversations with a colleague in the United Kingdom who runs a fellow named Chris Harrington, who runs a regional laboratory for metal analysis. And we sat and we talked about the inability to accurately get to that non-ceruloplasmin copper. And he took up the challenge. And what he did was to isolate the serum proteins first using chromatographic methods, and then using the very sensitive ICP mass spec, he was then able to actually recover over 95 to 98% of the copper in each of the peaks. And so what he did was isolate ceruloplasmin and found the copper in that peak. And so you can actually directly measure it. So you will know if you have total copper, which is easy to measure, and you have the ceruloplasmin copper, you can actually get to that value of non-ceruloplasmin copper easily. So you can see the difference in the patient with Wilson disease, that's small. And in the ceruloplasmin peak in a normal individual, it's high. So you would recover less copper here, more copper here. In an untreated patient with Wilson disease, this peak often is high, or actually the non-ceruloplasmin total copper is high, and this amount is small. Now, one of the famous PIMP questions for the boards is, what about patients with Wilson disease? Should their serum copper be high or low? And because the ceruloplasmin is low, and ceruloplasmin copper itself is 95% of our normal serum copper, in most patients with Wilson disease, except in the patients with true liver failure, the total serum copper is low, but the proportion bound to ceruloplasmin is less. And that's where we get that high NCC, and that's our treatment goal, is to lower that and prevent disease progression. Now I'm going to just briefly mention, and I'll actually skip through these slides faster than I intended, to tell you a little bit about what's called the Chelate study, which I had presented at the recent ASLD meeting, which was the first head-to-head study for a trientine compound with D-penicillamine for maintenance therapy, and then also just briefly about the use of tetrathiomolipdate, which is another compound under study where the phase 3 studies finished, and just briefly why we think gene therapy is going to work in these individuals. So back a number of years ago, I mentioned that George Brewer had tested the early compound ammonium tetrathiomolipdate, and then once we were able to get a more stabilized compound, we began to test this, and in particular, focusing on patients with neurologic disease, we felt it was very important. And what this compound does is it binds the copper to an albumin complex very tightly, makes it not bioavailable, and it may even put some of the copper into bile as well. So what we found in individuals was that the non-ceruloplasmin copper at the start, prior to treatment, is high or early in treatment. And then over time, as you treated them with this compound, that came within the normal range. And this just shows the percent changing over time. Now, in concert with that change in the non-ceruloplasmin copper, we also saw clinically that the Wilson disease scales we used for looking at neurologic function also improved in these individuals. And in the phase 2 study, we had about 89% of those individuals that had neurologic disease. Now, this has now been moved into a phase 3 randomized study that's been completed comparing it to standard of care, and we eagerly await the final, analysis of that data to see whether this trend has continued, and to compare the safety of the tetrathiomolipdate with our current available care. These are just some of the different sites that conducted this phase 3 study. Now, another study, the one I mentioned about comparing head-to-head, the chelate study, D-penicillamine for tetrathiomolipdate, may seem, to some people, well, why hasn't this been done for 50 years? And the answer is it just hadn't been done. Even though we've had therapy, there have never really been head-to-head randomized studies. Now, importantly, D-penicillamine gathered the primary ability to, by the FDA, was granted approval as the primary drug for treatment. And triantine, when it was first introduced, was granted only for those who were D-penicillamine intolerant. But those of us who've used both compounds think that the triantine is fairly safe and probably should have been evaluated in this mode much earlier for that. But often now, especially as the cost of these medicines has skyrocketed, there's been greater adherence to what the FDA it says, and so people have been getting difficulty getting these as primary compounds. But anyway, we hope that as this study goes forward, we'll be able to prove that they're non-inferior, and then that'll be accepted, and we can change the indication for the drug. So this was a multi-center non-inferiority trial that actually put head-to-head these two compounds. It was a heat-stable triantine known as Teta-4. And what we found in these individuals is that we started them to look, and we wanted to make sure we had stable individuals, put them through screening, and then we randomized them to one of the two arms, either to stay on the penicillamine or to give them triantine. And these are just some of the sites. It was conducted as a worldwide study. And what we looked at as for endpoints was back again to that NCC. And this was actually one of the first studies to use a very similar assay to the one I showed you by the Harrington Laboratory. So it's really a true NCC. And we'd use that as our primary endpoint. And secondary endpoints were our urine copper excretion, liver test, stability of the patient, clinical judgment that the patient is doing better, the neurologic score. And then we looked at safety for standard adverse events and serious events. We did a cognitive assessment, and as well as, again, looking at some of the other liver parts for safety as well. So in this study, we screened 77 patients. Now, interestingly, when you have a rare disease, you don't want to let anybody go because it's very hard to find these people to enter a trial. So what we did was, if the patient made it through the trial to be randomized, they were moved forward. But if they failed due to some reason that we didn't deem them meeting the guidance in terms of the guardrails of where their disease stability was, we coached them both to diet, we readjusted the medication dose, and we allowed them to re-go through that baseline period of evaluation. So we ultimately ended up with 53, and we didn't have to exclude all 18. 6 of them became eligible again. So that, again, in a rare disease, was important to keep these patients participating in a trial. And so at the 24-week point, which was our point for assessment in the patients who received 1 or 2 of the treatments, we found, and I'll show you the next slide, that these were the individuals for the urine copper excretion at the start. And then right at the time of randomization, you can see very early on, patients who were on D-penicillamine kept pretty high urine copper excretions. Those who were moved over to the triantine compound, the Teta-4, it decreased. Now, one might think that might be worrisome, except if you look at the NCC, what we found is there was really no change in that mobilizable copper in the circulation. So we postulate really that there's a potential for 2 different actions of the triantine. One is the urine copper excretion, and the second is some of that which is not absorbed, because it actually is less absorbed than penicillamine, may remain in the gut, and then secondarily block absorption from the diet. And so that, we think, is how that is giving us the equivalent action. So as far as safety, we didn't find any significant safety events with the Tetrathiomolipdate. We did find interestingly, some events occurring depenicillamine in the pre-randomization phase, which probably means we're underestimating the normal amount of complications from that medication, which is interesting. And then when we consider the liver tests in these individuals, we find that at week 24, there was no significant difference in AST or ALT. And so taken both from efficacy with respect to the secondary endpoints as well as the primary endpoints, of which there was really no difference in the drugs, we really felt this is truly non-inferior to depenicillamine, and we can consider this drug eventually as an appropriate maintenance therapy for the patients. And then hopefully we'll also show that it's a good initial therapy with less complications than the depenicillamine as well. Now, just briefly, as we move to the future, talking about gene therapy is really, and in the future, ultimately, gene repair as well may come into play, especially with CRISPR technology and other technologies available. We know that it's a monogenic disease. We know that our heterozygotes don't have pathologic copper overload. We know that the liver is really the place we have to focus on if you replace the liver and make the ATP7B function there. We know that from transplant. We know we cure the disease. Now, the problem is in transplant, we create a different disease, transplant disease, and Nick knows that well, that we're giving lifelong immune suppression and other complications arise in our patients. So we really prefer if we could fix that without the transplant. And we know also that, again, you don't have to hit all the cells in the animal models to achieve a correction of the disease. And that gave us hope that with gene therapy, we'd be able to partially hit some of the cells in the liver and then be able to achieve a good metabolic correction. And indeed, in a couple of studies that were done in the animal model using a mouse model and using the AAV, adeno-associated virus, as the vector, and a truncated gene for Wilson disease because the actual gene itself is a little too large to fit in the stuffer region, so a specially designed functional version, which was smaller, of ATP7B had to be put into that stuffer region. You could deliver that to the liver cells very effectively just by giving the AAV intravascularly, and you inject that in IV, and that hones directly to the liver and causes replacement of the function of ATP7B by the mini gene in the liver cells, causing correction both biochemical. In other words, you don't get any of the changes in the liver tests in those animals, as well as you prevent the hepatic copper from accumulating. And these were then taken to some level in primate studies as well for safety. And now we've actually initiated the trials, and we're screening individuals for that right now. The investigational sites for the Yvette study is at Yale, University of Michigan, at UC Davis. And we're happy to consider individuals who are well treated between the ages of 18 and 60. And they would then be given the therapy and monitored very closely to show mechanism of action. And there are two separate trials ongoing right now. We're very excited about that. So I'm going to show you in the last 2 minutes before I jump into the final, just that we are doing a registry-based study of Wilson disease at our center. And it's a collaboration between multiple centers in the US and in the UK and in Germany now. And we're collaborating both with the Harrington Laboratory that's been doing the non-ceruloplasmin copper work, and the Hahn Laboratory, who's doing both the DNA analysis and the peptide analysis. And we're really trying to define better what the natural history is, look a little bit more about the phenotypic variation, and find better methods for evaluating our patients. We're doing a very careful liver, neurologic, psychiatric follow-up of these patients. We have a biobank. We're using our specimens for both the metal analysis as well as the peptide analysis. And that's led to a number of publications. Just to show you as everybody is living through our pandemic, the effect of a pandemic on clinical studies. You can see this was our initial enrollment starting in December 17, and you can see what we flatlined here somewhere about March 2020. Similarly in our pediatric enrollment, and we've now back into the growth phase of this. So it's impacted all our lives, and certainly that of doing the study. And it's going to be challenging because this is also a longitudinal study, and we're going to have to work out how to deal with data, as all clinical studies have during this time. Just real briefly, we've looked at the depressive disorders in these individuals, finding that we do find a higher degree of that, and that we feel the bottom line was that we need to screen for depression in our adult population in particular. We also found that both neurologic function may change the functional quality of life patients, but more importantly, the mental health has a higher impact on our patients' quality of life. And lastly, we've noticed that as the patients were entered in the study, and again, these are patients coming from multiple treaters, we found that a higher percent of people than we thought had abnormal ALT and AST, even on therapy for significant periods of time. And when you look and you try to see, is it individual to one therapy or not, it turns out you find it in patients, whether they're zinc, trientine, penicillamine, or on combination therapies. And that gives us, important look into our population, and gives us a challenge of how to improve that for these individuals as well, as we start to look at the proper measures to follow. We can see in some individuals, especially those who had higher values in transaminase, perhaps they were undertreated for a period of time or not following diet. So we're going to have to explore that much further and try to sort of hone in on that. And then that can really take our current therapies and improve the treatment with that. So in summary, you have to consider to Wilson disease when it's appropriate. It's important to establish the diagnosis because treatment's lifelong, but establishing that uses this combination biochemical clinical data, and recognize that when you want to send for an ATP7B mutation analysis, you can do that now. And there are, it's clinically and commercially available. Our medical therapies for Wilson disease, unlike the episode of House where he says take 4 penicillamine and basically call me in the morning, do require monitoring to make sure they're working, make sure the patients are taking them. We hope that we're going to find sort of the one ring that binds them all in the NCC assay, that may be the best biomarker for following our treatments. And we're very hopeful that the gene therapy and future gene repair offers cures to our patients for this disorder, and be on the lookout for our new guidance coming in 2022. And lastly, back to your code for your CME, and this wonderful view of the Grand Canyon climbing. I did the climb up from the through the Bright Angel Trail, and it's much like it was a slog for 8 hours. And I can tell you, being through this pandemic is sort of likened to a very long version of that slog up. But when you get to the top, the view is beautiful. And so I hope we'll be back to that beautiful view again in the future. Thanks for your attention.
Dr. Schilsky, thank you so much for this really just wonderful review of Wilson's disease and where we have been, where we are on diagnostics, the clinical assessment evaluation, and the really exciting arenas in the therapies and advances that have gone on. It's a tremendous translational story from also basic clinical science and improving the outcome of patients. I just really want to thank you. I'm sorry our time is up for today, and again, just to thank you for sharing all of this with us, and also for making us aware of the new chapters that are yet to come and unfold in the treatment for Wilson's disease, as you talked about, the gene therapies that are currently being studied and looked at. So I want to thank everybody also for joining us this morning, all of the participants. I want to thank also Dr. Persopoulos and the hepatology group for inviting you for this Carroll Leevy Memorial Lecture and your acknowledgments of him in your presentation as well. So thank you all, and I wish everybody a great rest of the day. Thanks so much.
Thank you for the opportunity.